So, we start with the human resources group. So, what is the report?
بالنسبة للكاميرا أنا معي دايركت.
Okay.
Put it in your pocket or something.
أخذته في يدي.
The questions first.
Okay. Yes, please. Yes.
Okay. So the human these are the other ones. So for the human resources group, we are addressing training for physicians and nurses as part of both the undergraduate and postgraduate curricula, as well as capacity building for practicing clinicians who may provide primary or secondary palliative care. It also covers specialist training, licensing criteria, and palliative care clinical guidelines. We did not address clinical guidelines.
That's all right, we did.
Okay. So the questions are, what are the priority needs for palliative care education in the region? What licensing criteria can be applied effectively in the region based on existing standards? And drawing on the collective experience, what palliative care training should be recommended in the region based on WHO recently published guidelines on palliative care, modular, expanded modular, etc.
Good. So we had a fruitful discussion. We had input from Morocco, from Sudan, from Pakistan, and we realized that there is a difference between the different countries, the 22 countries that we are here speaking about. There are countries with no any active training in palliative care. And so speaking about the levels of training, level 1, which is like an introduction into palliative care, which is essential for undergraduate students, medical or nursing. It is important that training, level of training is very important to orient future doctors and nursing about palliative care, to involve them into palliative care, also to have them know which patients need palliative care. But the most important one is level 2 training, which is like 100 to 120 hours. We have examples of that in Morocco and in Sudan. So but in both countries we have Saturdays. So we are now proposing a course at this level, level 2 training, to be available in each of the 22 countries. This is the plan. And this course is run by local trainers mainly, and must be multidisciplinary, because this is the way the team is going to function. So we want nurses and doctors, psychologists, pharmacists to attend together. And we want the involvement of the Ministry of Health, the Ministry of Higher Education, because we don't want to train people and then they are not recognized and they are not compensated for that. So we want them to have certificates, and these certificates will allow them to practice the service and to get a compensation for that. So we are speaking of, we disagreed on the period when this should be done. Some people said within 2 years it should be starting, kicking off, but some of us were thinking it should be even faster than that. The most important thing is that we want to involve the ministries of health. So develop the curriculum. I think this will be the job of our network. We can share the different curricula that we have, and even those who are not attending. We know some people in Jordan are doing very nice training, so we can put all that And the syllabus and the training even itself should be available in 3 languages, in Arabic, in English, and in French. We want to involve the ministries, especially for licensing, accreditation. And what is this word?
Syndicates. So we were saying that ministry involvement is essential, but in some countries like in Lebanon and Pakistan, you have the 2 bodies. You have the Ministry of Health that's involved in regulation, but then you have a syndicate or order of professions, so for nurses or physicians, that licenses and manages continuing education and things like that. So they need to be also involved in this process because they will be critical in licensing and making sure that people meet certain professional standards.
So the way to go about it is that maybe there's an initiation from the WHO to the ministries of health, for example, to identify at least one center where there can be a memorandum of understanding. And the WHO might be providing some technical support in terms of books or advice, and of course sharing the curriculum. And we want these centers in each country to accept candidates from health professionals openly, not to be like restricted to their own students, for example. And even the fees paid, because it's an issue in my country, should not be exorbitant, small fees to be paid. And we want to link our work, of course, cannot be possible without having in the policy group the licensing, the dispensing of opioids, the availability of opioids, the compensation for these trained staff who are going to do the work. Then, after this identification from each country of a center, then we have to identify these countries. Some countries will be having already people practicing palliative care and training people in palliative care, and some countries where we don't have trainers, then we have to see how to go around for these countries which don't have trainers, in that we create training opportunities, or even stages. People can go and stay for 2 months in another country to be trainers. And important for us to the selection criteria for the center, and the selection criteria for the trainees. For example, when we are, I think it's trainers, correct? Okay, trainers. Okay, so selection criteria for trainers. Nobody can come and say, I want to train in palliative care, where they are not doing the work in palliative care for several years, when they don't have more certificates in palliative care. And it's very important, the follow-up of these, both the centers by WHO, for example, and the follow-up of our trainees. So these graduates, after they do, let's say, 8 weeks of palliative care at the second level, they are ready, should be ready to do the work in their setting. And we need to follow up, like, for example, by writing a report. We ask them to write a report after 6 months to feed us back. Even we can ask also where they are working, the place of work, how they are doing. Questions?
Just to add just a couple of points that I think were discussed in the group. One, I feel it's important to clarify why we decided we're going to focus on practicing physicians and nurses and not undergraduate curricula. We felt that there was, just from the discussion and a few of us in the group, that there was huge variability in the region in terms of what medical schools and nursing schools are teaching, but we also felt that in most places, palliative care is getting integrated into undergraduate curricula with, I'm sure, varying degrees and levels in terms of quality and extent, but it's happening. So we felt like if we want to focus on our efforts one place and what meets the WHO recommendation of integrating palliative care into primary health care, this made more sense. So this is why we chose to focus on this. The other thing, that to clarify the stratification, we felt in our discussion that these trainings need to be different in each country or country-based. So if we decide that we want to send people to Saudi Arabia, for instance, because training is pretty well developed there, there is going to be resistance. But if we develop a group of trainers within each country, it will be more relevant to the country, it will be more accepted by providers in the country, and so there won't be this push and pull between, you know, which countries are the training countries, etc. I don't know if anybody else wants to add something that came up.
Yeah, I think we're talking about the criteria of selecting the trainees, and we need also to put certain criteria that make sure that these are going to really benefit and to practice it. And this is why we requested a 6 months report, because not everybody, because from our experience in the last 3 workshops we did, same faces, same people were coming who are already experts in palliative care. And so these are the most important now, to make sure that we really provide more education to more people in the region or in the country at least. For the undergraduate, we were talking about also, in Kuwait we do have some undergraduate and postgraduate for some kind of course or training or workshop, but this is very individual, which means that contacting the dean of each faculty was this arrangement done, which we want to spread it more. And I think with the countries where they have like Pakistan 87 medical school, it's a bit a challenge. In Kuwait, we do have one only medical school, so it was easy to. So we have to overcome these challenges and try to find a way through the Ministry of Education or higher education, how to integrate it in the under or postgraduate, at least, training or specialties.
Do you want to have a discussion from the group now, or wait till after all the presentations?
No, I think it might be good that we capture, because maybe I try that for each of the themes we have a time for the panel capture, and maybe try also to highlight what would be the action point on that specific item before moving to the next. Of course, they might have some interrelation. I've seen that some of the other that you are giving up for the other groups might be also relevant for us together.
Okay. For education and training, usually using the African experience, e-cancer modules, which give the chance for everybody, everywhere in each country, the chance to register in palliative care course with the modules, and he cannot go from modules until he have exam, and he will go to other modules until he complete the certificate. Then after that, they will have intensive training, hands-on training, something in 3-4 days. This is save a lot. Instead of sending people for training 120 hours with accommodation, traveling, everything is very expensive. Making the expenses less, we can use a model of online education. If he passes and certified, he can come and attend the training center. And this is quite well known in basic life support and advanced life support course, which is a very skillful thing. The audience need to have a basic knowledge and certified before coming to the workshop. We might have the same idea.
Just to add to that, what I was talking about when we say about licensing, probably Ahmed give more explanation that we do have this basic life support, and then we can do the same for the palliative care. I mean, it's mandatory for promotion in in our system. And it should be reviewed every 2 years because, of course, the update of course. So it's very easy to be doing something similar in palliative care. And this is what we added here as for licensing or in general for promotion. So it's a 1-day course, like 8 hours, but you have to prepare first with some basic knowledge. They give some information or a book. You have to study it, and then you go for the practical, then you have exam, and by the end of it, you will get the certificate. So this is a very successful experience which can be done also for palliative care.
Thank you. So my question with this, which is great, is do you have a clear vision in your mind on the difference between generalist and specialist palliative care? Because when it comes down to training and workforce, you need to be really clear, and it comes down to structure and clinical services as well. So what's the role of specialist, what's the role of generalist, what's your vision for who's going to provide what at the end of this? And also coming back to the issue of quality, the problem with training always, of course, in palliative care, it's not teaching a clinical skill so much as helping people to think differently and create new care pathways and behave in whole new ways. So what's our vision, do we think, behind this? That yes, you train people, but actually you're going to transform health systems, you're going to refer, you're going to communicate, everything's going to change. And how's that change going to be sustained? It becomes such a much bigger vision, doesn't it? And I just wonder what your thoughts were about that.
Regarding the generalist and specialist, in fact, in our countries, what we feel that the main important thing now is to focus on oncologists, on people who are dealing, for instance, with such. There is no point now of going to the family doctors and to go to the orthopedics or to the surgeon and train them. Let's start with the doctors who are in contact with the patient with the advanced diseases and so on. And we can start with the cancer oncologists, for instance. We can start with the nurses who are working in oncology centers. Probably we can work on some patients with the neurological diseases and so on. To focus to make it's big. There's no differences too much between general, because we don't have this luxury of providing palliative care or we don't have the manpower, the resources to provide such a service. So let's focus at the beginning on these people. Then, I don't know in the big countries how they do, but I think it's much easier when they focus on this group.
This was a point of this is a point of disagreement within the group. I just want to say that we do. I feel very strongly that this should be in primary care, and this is a WHO recommendation. So I think it's important to provide this at the primary care level, and yes, shift the health system. And we did talk within our group as well about having, so the people, you have the trainers in the country, and those are the specialists, and then they're training the people in the primary care environment and secondary care environment. And then as part of this training process, you create these communication systems so that the primary care provider and secondary care provider has a link and can reach out more centrally to the palliative care specialists if they need support, if they have clinical questions, etc. So you're creating this communication relationship, and they feel that these specialists are more accessible to them. And I do want to add that if we focus on the training and we don't think about the policy dimension and creating systems in which these people can actually prescribe, then training them is useless. So really these things need to happen in parallel, and creating policies where providers can prescribe and have access, because in Kuwait as well, opioids are only available centrally in hospitals. So working on making opioids available in regional and local pharmacies, and dispensing is possible and prescribing is possible, is an important part of the system. Otherwise, we're still stuck in the system that we're in.
I would like to clarify a few points about this training. It's a level 2 training, but it doesn't mean we are not targeting the primary health physicians. If we give a training of 1 week, it's not enough to start the service. So we want to impact on the service provision. So it's a level 2 training, but who is targeted? Especially primary family physicians or registrars, oncologists, nurses, all the different specialties. And so this is one thing. It's in the country, so there's no traveling. It is face-to-face, because this is the way you can depend on these people to give the service, because they have met, they have heard direct. But online, it's a little bit difficult. It's getting some knowledge. But if you are training some people, for example, recently we made the training of 50 family physicians in their 3rd year of residency. So they did 2 weeks, the same course for 2 weeks concentrated. And now they can start, they can work. They don't need to. And of course, I think this is the job of our network to follow up on this activity till it's done. And also within the country, because these people are going to give generalist palliative care. So they, within their country, they are identifying their trainers. They know which one to contact. When I started in 2009, I was contacting Dr. Ahmed Assaim in USA by email. I have this patient, and so that is my only reference to have. But it's a way to start.
You have only like level 1 basic, level 2 intermediate, and where is the advances?
No, it is there, but this is, we are concentrating to do this one as an activity.
Okay, but you should put a plan. It's an immediate action plan and also delayed action plan. So you put the 3 levels, the basic, the intermediate, and then the advanced or level 3 for specialized palliative team or specialized palliative physician or nurses.
Okay.
It depends on the
We
time
have plan.
frame.
This is a plan.
And we talk about 2 years, so that we could achieve these things, but we want something to be achieved.
We were going back to the directions Celine gave us yesterday. We're trying to keep it succinct. We're trying to keep it very focused and achievable objectives, deliverables that we could expand on this as much as we wanted to. But that's why we wanted to focus on it, and we're trying to follow the WHO guidelines to cover as many patients as possible. And with the intermediate level, we think that it's reasonable in terms of the time frame, and we're reasonable in terms of the approach that they will be able to deliver the care that we're looking for the masses in general.
Can I make?
Say something that Professor Harlan is highlighting, and how we link this to the policy aspect, to the service delivery organization. You will be going back to the countries with a proposal that doesn't fit the current situation in terms of service delivery models, because it doesn't exist, or it's just in pockets. So there should be one policy consensus decision at the national level whether or not our proposal is something that they want to go for it. You are going to come with a training program, so okay, but where does this fit? Where are we going to integrate this? So is it demonstration site or pilot or whatever? Because there should be linked to a place where those people are going to change something on the ground, and change the practice, and there might be some supervision and support, so that they can then, whatever they get out of this training, we put it in practice. If it's not there now, we need to create it. And then we have to decide that this is an approach that the country wants to adopt. We would like now to invest in palliative care. Then we have a method support for WHO for training a certain number of people. We need to decide where. Are there people that are already there doing it and we try to improve and look at the way they are doing it and support them in improving the quality cycle? Or is it starting from scratch for some countries and we're actually starting in places? So in that case, we need to decide what are the criteria, not only for the center to train, but where actually we are going to implement any changes. Specifically at the primary care level, I'm not aware, most of our countries do not have it integrated at the primary care level at the moment. So basically we're starting to push the boundaries on something that doesn't exist. And then you have the health system requirement to do that, like access to medicine, health information system, beyond the training. So I mean, I think we need to anticipate this, so that we don't have a very nice package that it doesn't fit anywhere, because the policy dialogue hasn't happened. There is no consensus about where this is going to be implemented, and some of the system requirements that need to go for the people to be able to implement whatever, as you mentioned access to medicine, but I don't know, capturing some aspect, the health information system, the referral path. So it's nice that, of course, if you are having a second level, but you have linking with the trainers that are the one who are the referral center, and you create that referral system. It has to be formalized, I think, in a way that once you have finished this activity, going back to those countries, there's a lot of preparatory work and policy dialogue and having a consensus of where this is going to happen. Because otherwise, I think we have a nice product, actually it's not fitting with the reality of the diversity of our countries.
So actually, in connection with that point, I understand the point that some medical schools are integrating curriculum in palliative care. But I think it would be a huge missed opportunity not to recommend for the region to make a recommendation that all medical schools must include training on palliative care, to have at least an outline of curriculum and two basic models or integrating palliative care content and existing courses throughout the course of the 4 or 6 year medical school, as opposed to a discrete course, usually in the final year, lasting 1 or 2 weeks. That would take the place of the level 1. And the medical schools already exist. It might not take extra funding. And if we're constantly trying, if the effort is to constantly try to train physicians who've already graduated, it's always playing catch up. Thinking toward the future, let's start making sure that every medical school graduate in the region has had basic training in palliative care, and that will just facilitate and make much easier the intermediate level and the specialist level training. So I'd like to propose that one of the recommendations should be medical schools must provide some kind of training in palliative care, and this is what it should consist of, and that could come from a regional organization or even from MROs.
Any further comments? Yes, we were thinking about the level 1 training, but especially when we are speaking about countries where there is no person trained in palliative care. So at least to have it's in our mind, but first to establish the level 2 training and then move forward. And I think from this network, we can have a lot of opportunities, because between countries, we can exchange training opportunities. I can see in Saudi Arabia and in Egypt, we can send people from Sudan to stay for stage for 2-3 months. So I think we can have a network of possibilities within the region to be listed also, maybe in a website or whatever mode. No further comments?
Did you touch upon the guidelines?
We did not.
No.
Yeah, maybe we can look at the questions again. Licensing criteria, we addressed that we need to work on the policy level. So this certificate should qualify people for licenses that would allow them to prescribe, basically. But we did not touch on the guidelines.
Clinical guidelines, yeah. And perhaps we're just trying to fill in some aspect. We have a for what I mentioned, but I mean, on the actions for the health, of course, in education, I think it's clear what I mentioned. Just perhaps about specific deliverables or that you foresee. So basically, you have a curriculum for the second level aspect. Is it enough to be implementable?
We felt we had enough curricula that are already ongoing. Nahla's been working, and Asma has been working in Morocco, and we know that Muhammad Bushnaq has been working in Jordan. So we have 3 curricula already in 3 languages. There's the one recommended in the WHO manual as well. So an integration of some of these together so we felt that was feasible, and we felt we could start with that. But given what you raised about the barriers with governments and on the policy level, it makes more sense to get buy-in from government levels before we.
I think that what I was thinking is that the curriculum is, of course, the core of that activity, but we might have some policy dialogue that once we have decided what other country, I mean, we would try to spread it across the region, but not all countries are on the same level of the discussion, is how we are going to prepare ourselves for those discussions. Who to contact, what are the entry points, maybe if we have countries where we have already sites, where things are ongoing, it's easier than for countries that are starting from scratch. We're just adding another line of budget for them, or human resources constraints might prevent us to start on a pilot. So probably we need to think as part of the group, not only on the development of the curricula, but how this will be then discussed with the ministries, and we can help you to do that. But I think if you have knowledge of countries that are already have sites, where like Sudan is an example, maybe it would be an interesting entry point for us and to support the discussion.
Yes, the idea is that you make a memorandum of understanding or an agreement with the Ministry of Health and also with a center to identify one center in the country at least. And then the idea is that it's not adding to their load of work, because this is going to be, for example, here we put it on Saturdays because we want the candidates to be able to come and attend. So if we put it on a normal working day, so you have this problem to have them take a holiday from their work or leave absence. But to put it on Saturdays, it's possible for them to attend it, to have their certificate in 6 to 8 weeks, and then they continue their work. For the institutes, it's a privilege because this institute is going to be a center for training in palliative care. It's going to have the resources, it's going to have the books, it will have to have some, it's going to have the support to have its people trained to be trainers. And I think it's a positive aspect. And I don't think if we don't want it to be, in some countries there's no problem of money, but for other countries the issue of money is important. So we have to think of what do you call it, self-sufficient cycle, self-sufficient, sustainable.
So in our group, for instance, both Asma and Nahla are doing trainings. Nahla feels that she has access to government and government buy-in already. Asma has been doing amazing work, but she feels that the barriers in the government in Morocco are going to be higher. We've been doing trainings in Lebanon through Belsam and through AUB. Yesterday, we had a very strong commitment from the Ministry of Health, so that could be a wave we can ride. So maybe we can look at the countries in the region and look at the availability of centers and potential trainers, as well as the barriers and how easily we can access government, and think of starting in a couple of places. And if we do that and do it with pilot demonstration projects in mind, we really should build in evaluation criteria and clear criteria that would be of interest to other governments, so we can share and then scale this across the region. So that would be essential if we want to start in certain places and then roll it out.
Just a quick point to follow up on what you mentioned, Eva. I think it's key to have this policy dialogue at the beginning. I was thinking if you are building a house and you want to put windows with no walls, you will get in trouble. So we have seen a number of very good training initiatives with very little impact because the commitment of national authorities was not present at the beginning. So I think this has to be conducted with a very clear and very pragmatic direction on time frame. So how many people do you want to train in which time frame? You mentioned 2 years, it might be slightly different depending on the countries. And what you just mentioned, Hiba, how you can evaluate, because this is not specific to palliative care, but many people go from training to trainings and you don't see what is the real benefit for the health system. So I think this issue of having a national plan, including, and probably at the end of this day we will have the different component, but including expected outcome of the training, this can help policymakers to commit. And the other point I wanted to raise in terms of collaboration, well, obviously this is where WHO can also contribute in this dialogue with the local authorities. So we can try to help. And finally, something which can also be helpful at the global level is to share experience from one region to another one. First, trying to avoid repeating mistakes, and second, also benefiting from good lessons.
Just as you have the microphone, I was thinking of how this translates, and you alluded to it, into our WHO work. In other words, how can we support this beyond, I mean, we are not experts to review the full content, but we have an expert and we trust, I mean, but they will come out with the curriculum and syllabus. Then we have actually to help implementing it. So you alluded to the policy dialogue. I was thinking about what would be the level maybe of HQ to do what we are supposed to do at the regional level to support the discussion. We have a quite clear understanding of where the countries sit in terms of agenda settings, the reform that are taking place in those countries, what are the entry point, and where potentially we can help. But I don't know if this for you something that is viable from a WHO perspective, and how we can help so that it will not come out 6 months down the road with a curriculum that people have put efforts and extra time. Then we say, well, basically, now we don't know where to put it because it's not taking, the country are not.
No, I think it's hearing this from you. It's also very important for us because it's an indication of what we can and we should do. Well, as you know now, the whole organization is focusing on country results. For example, at HQ level, we have to demonstrate what is the impact in practice in countries, which is sometimes quite difficult. But if we do normative work, publishing guide, for example, we also need to demonstrate how this is translated in countries. So if we can show that there is a number of countries, well, we have 6 regions, we can also try to select in each region countries in different levels and with different kind of needs well, I'm not personally, this is a personal limitation, I'm not always using the concept of demonstration project, but let's say country project with this clear commitment based on a policy dialogue involvement, the region, the WR, the regional, and HQ can also help at this. And this is also the best way to show to other countries that this is feasible. with simple interventions, and because sometimes when you think about countries with so many priorities, in the middle of all sorts of crises, well, obviously you have a group of people interested in palliative care arriving at the Ministry of Health, and people, well, they don't know why this is a priority. So I think in this dialogue, you also have to link to other priorities. This is why I think it's important to, for the time being, to link to primary health care, because this is definitely the priority for all countries. But also, the work we did in palliative care and in humanitarian crisis is also important, because here you can make a revolution. Really, you can change the things. So, yes, you need to discuss with local authorities, and this is the mandate of WHO to help you in this discussion. You need to exchange with other countries from the region and more globally, and this is where we get also support.
Do you want to go ahead? I think here's where the evidence needs to come in. So in our discussion with ministers of health, we have to explain to them and to show them the evidence why we need to implement more palliative care. What is the changes going to happen in the health systems? What are the cost benefits, and what are?
So just two things that came to mind, Naisha, when you were talking. One is something that we can get from on a global level from HQ that would be very useful is to share outcome measures and evaluation tools and things that have worked for different people. So having people share measures and indicators that are useful, so we're not reinventing the wheel, is very useful. The other thing that you mentioned, and I'm just, people might think this is ridiculous, but making the same mistakes. We all love to share our successes. We don't love to share our disasters. And I think if we could have something, thinking out of the box, like a forum where we share our mistakes, and I wish I had known that, or I wish I had done that, that would be very useful and save a lot of money and save a lot of effort and heartache. And I have at least a couple of disasters I'd be ready to share with others.
Brilliant failures.
Yeah, brilliant failures that I've learned a lot from, and so that people who are excited and passionate about this work don't have to repeat the mistake that I've made for them, and I can tell them where I made the mistake.
Further comments?
Are you self-autonomous or self-independent in this group to be able to deliver something in a given time frame, or you needed some resources or support, or who actually are going to involve deliver?
I think we need from every country a representative. I think already we have people with us here, and then there are other representatives, so we can get the contacts. And then we need to contact the Ministry of Health, so we need the WHO to interfere in that. About the curriculum, I think we can circulate it by emails, by Dropbox, whatever, and we can have a discussion on that. We can have Skype discussion.
Because what we can offer, I mean, we were discussing this today, we can explore a platform of the overall group that can be thematic, and you can have a sub-folder, some sub-entry point where you can maybe have a depository where all the document can be shared. There will be a chat or something, so you can also by email. I mean, I think Easy Collab allow you even that when you send an email, it goes to the platform, so you have the track of it. So don't lose if you have 100 more emails per day, at least you have the.
You can also turn that function off.
Exactly, so you're not bombarded.
I think that's what it is.
We can look at that aspect. So up to you then to organize yourself and one of the group, but we can organize webinars also to see progress, review, I mean, the policy dialogue with countries, bring it in the country offices and the WR on board if you're moving. What would be good is that at one point you put this into a kind of Gantt chart with some milestones and how the activities will unfold, and pull us in when you want or think that you need, the input or our support.
Yeah, I think we can definitely do that as a group. My voice is not enough. We can definitely do that as a group, but where we would need WHO regional office support would be maybe to share what we're hoping for from the level of government, and then your WRs can look at feasibility and accessibility and interest from local governments and come back to us with these are the low-hanging fruit, and these are the impossibles, and these are the in-betweens, and then we can set a strategy based on that.
Again, you can decide if this is a good idea or not, but again, I'm continually struck by the uniqueness of this meeting, and it's not possible today to create a Middle East region palliative care association. But if this group could have a name and the assumption that it will meet again, it could be the basis of something like that. And if this group then has a sort of an identity, then it can make these recommendations. And this is going to be true for all three groups, because all three groups are going to have ideas.
Address it this afternoon. The point of having the governance structure, how we organize ourselves,
Okay.
and we can reach out to other. You said that there was already one subgroup in the region of all the people working in a different way, where we could decide about how this has an identity. But for us, if we are calling for an expert group, I go back to my regional director and say, okay, this is an entity that exists, these are the names, this is the number of country representatives, and this is a work plan that we can come out with and propose this. So it has an implication for us internally as WHO, because it's not just an informal group that we have set in a meeting once in Netherlands that we would like to use. It's not by chance that we changed you are entitled as temporary advisor. You came here as temporary advisor for WHO, not as participant that are passively there. When we say a temporary advisor, we refer to experts that are providing some work, some support for the strategic direction of WHO. So an expert network is not something informal for us, something that we would like to work with you to actually support and empower work plan, our strategy, and it's an extension arm of WHO, like we are doing it with collaborative centers that are working with WHO. So the way I say it is not something that is just a kind of informal group that if you have a certain level of commitment when you are coming here, take a look of your time, and if you want now to propose activities, I assume that all of you have a responsibility to say, I would like to deliver on this, and we will require some kind of support. The main support that I can offer is what Maisha has mentioned, is to liaise with the Ministry of Health in the policy dialogue, is to have a convening role, is try to take as much as we have as normative work and strengthening it, and then we're sending it back to you and to our country. This is what we can do, and then do some monitoring and evaluation of the progress of our time and support.
Would it be useful then this afternoon maybe to discuss among this group whether there would be a spokesperson for the group, for the Committee of Temporary Advisors on Palliative Care in EMRO, who could then, on behalf of the group, make recommendations to give a little extra push beyond, or maybe to say things that you as WHO staff could not say? Something to think about. See, I'm always getting into trouble when suggesting trouble.
Actually, I don't know exactly the procedure at regional level, but it might be slightly different from headquarters. The way we establish expert groups in headquarters is quite formal, more or less, and it's under review currently. So I cannot commit for the long term, but if you want to have an established group which is not the case so far. This has to be an initiative from the region, and that would be an advisory group. So, for example, in headquarters, we sometimes have groups of experts designated by the DG. This is extremely formal, with a report to the executive board every year, etc. And much more informal groups. This can be useful. Something I wanted to mention, well, if we also have to be pragmatic, because it depends really what you want to achieve with the group. But if you do that, you have to be sure that this is reflecting the whole region and all countries. And something also you have to keep in mind, I think it's important if you want to have a more long-term commitment, is at some point to meet with delegates from countries, from ministries of health. So far we are here with a group of experts, but this is different from having a typical WHO meeting with people who are not coming because of their expertise, but because of their mandate, so they come with the name of their country, and that's it. And sometimes it's important for the policy dialogue, for example, because this is where experts can enlight the policies. So I think it's good to think a little bit more, and maybe we cannot decide today what would be the best status for an advisory group, and that would be terms of reference, and also how this group would link with other regional instances and interact with representative countries.
Just maybe we have a very few examples, but in the past, usually we come up with a list of people that we know in the field. We go back to the WR to have validation. So they go back to the ministries and say, okay, these are the very good people that we would like to select as part of the advisory group for the renewal for a certain period of time. In 2 years, it can be something that we discuss about rotating or who is there, because we cannot have 22 representatives on a group. So we might have to select maybe a certain number, maybe 10 maximum, like we did in all the past. And then we can say, okay, every 2 years there will be a change. Yeah. So we would like to have a good representation across the region, type of countries, some countries that might be in conflict, so that we have the feedback. Usually it works pretty well. The thing is that the network has not been very active. It's not more about the validation from the country, because most of you are already known in your respective countries. Sometimes when we have political issues, some people say, okay, but this person, Minister of Health, is not very happy with it. But basically, most of the time it's, yes, go ahead, and just keep us informed. So I think that level, of validation from the country and having them involved, once we start the discussion at the country level, we bring those experts as temporary advisors, as consultants sometimes if we are in somewhere. I think as long as we have the dialogue early on with the countries, that we have the validation, and they see that they have been consulted, I think it will. Okay, we drafted some very early in terms of conferences. I didn't want to open up the discussion because we have it in session in the afternoon. So, but then we can discuss, what could be the mechanism. But probably we have less formal as it is in HQ, which gives us a bit of flexibility and agility, I'd say.
I think it's time to go to the next group.
Yeah. So we will move to the service.
Should we bring in this one?
Sorry? Okay, we can stay in there. What we're doing.
Medical services to be offered over the next coming 2 years for developing a core or an expanded service in palliative care. We were 4 people or 5 people from Saudi Arabia, Kuwait, 2 from the United States, and myself from Egypt. Qatar. To answer this question, we thought about the basic pillars of palliative care. These are our interventions, or that should be formally applied, is to prevent and to treat physical suffering in all means, pain, any symptom related to physical, psychological, social, spiritual, and existential. Suffering for us is unacceptable. So suffering could have different aspects, and especially can continue after the loss of the diseased person, the patient himself. So we thought also that we should have an intervention to prevent complicated bereavement, anticipatory bereavement, grief, and complicated bereavement. This on 3 axes. The first one is the patient. Second, which is also very important, the caregiver or the family or the nearest people to him. And the healthcare team or the care providers, palliative care providers. As regards the levels of providing this, of course, there are 3 different levels. For the time being, these palliative patients are seen at a tertiary care center, but this cannot go on indefinitely. They are being referred to their homes, and now comes the role of the primary mobile care teams that will be always connected with the tertiary care center, getting the guidance and the best form that we could find, especially in big countries like Saudi Arabia, geographically I'm speaking, or Egypt, or maybe Algeria as well, is to have the mobile teams going to their home, providing the best possible care to them. Ideally, it will be nurse-driven and with the consultation from the physician of palliative care. And also he will be, or she will be, guided by the other members of the team, the psychologist, social worker, and the spiritual chaplain. If possible, for some nations who can provide healthcare visitors, if available, that would be also good, because it's less costly, they are practical, and it's an opportunity for both parties. The healthcare visitors are going to be earning, because in my country it was existing, but now it's not anymore, and I see many young people finishing school without work. It's an opportunity for them to get a work, and a helpful work. It's gratifying for themselves in the sense that they help others. They will feel that they are doing something very beneficial to the community and to the sick person and to the family, to the community. And the community also is going to be helping them by finding them an opportunity to find a work, a permanent job. Regarding the secondary level of healthcare, of course, we have three levels: tertiary, secondary, and primary. Secondary centers, or what we call regional district hospital or general hospital, are very important because usually tertiary centers are far away, are one or two in the capital, and they are very busy centers. So very often, if there is a problem, the secondary center is going to be acting in the sense that the patient will be going to the secondary center, but for the time being, I'm not speaking about some nations who are far, far away in advance, like Saudi Arabia. I'm speaking about my own country. Central hospitals or district hospitals are still not yet equipped to provide the care for a palliative patient, whichever disease he has got. And he might be even told immediately from the door of the emergency room, oh, no, you go to your place where you used to receive your treatment. We are not equipped, we cannot provide you the basic things. So this is why it's important that we provide for these secondary centers training, a very, well-tailored training program for the doctors, the junior doctors, for also the specialized doctors, if it is cardiologist or pneumologist or pediatrician, as well as the team, the nursing staff there, the psychologist in that hospital, and the social worker, in the sense that they do not send them back to the tertiary center or back home. We cannot do anything for you. You are too much, your case is complicated, okay? Of course, there should be a continuity of this training or a consultation between the secondary team or secondary center, medical center, and the tertiary one, which is the very big, highest authority in the sense of providing palliative care. This can be done by regular training from time to time, or by direct consultation using the simplest way, the mobile phone, the service now that we are having for free, like the WhatsApp. Send questions and get them immediate answer. What to do? We are having a case presenting with severe agonizing pain or intractable diarrhea and vomiting or sense of breathing, suffocation. What can I do? Okay. Of course, the tertiary center remains the most important, but we should help these tertiary centers to be less busy, to be dedicated more to newcomers and to train secondary people, secondary hospitals, and also provide training courses for, as I said, for the primary care center, which are spread all over the country. We are having in my country the rural health centers as a primary care center, everywhere, every village, more than one or two per village. So these can be, as I'm talking now about, again, the primary care center that can provide this service. But the tertiary care center is going to be the multidisciplinary, the mecca of the fief of this palliative care. The people who are going to be working there should be very well trained. They are the advanced palliative care specialists. And they can train the others and they can act like a training center, like what is being done in Saudi Arabia. They are providing, and even we had this good news that was told to us that the Kingdom of Saudi Arabia can arrange, Dr. Sami will tell us about it, training for those that need advanced specialist palliative care program under certain circumstances and certain conditions, so that they are well trained and they can return back to their home country and serve in the region. Of course, a country like Saudi Arabia can very, very well participate in this training program because they have got the know-how, the experience, and willingness to do it. As regard quality, the basic quality standards, and there is no, excuse, we cannot excuse ourselves if we forget to provide the availability of the essential basic medications. Dr. Kaur yesterday made us see a list of basic medications that should be available, whether at the primary care service or secondary service. They are basic. We are not only ensuring standards, we have to have quality service. And this can be, or we should work on it, develop guidelines or guidance for high quality service so that the person who is in need of palliative care, his family, and even the healthcare providers do not feel that they are alone, abandoned, rejected, neglected, or that they were not really taken care of because they are not a priority. So of course, there are some guidelines, there are some developed guidelines. We will take some of what has been used in Saudi Arabia and in the region. If there are others, we are going to be like collecting these and pooling them so that we develop over the upcoming 2 years real regional guidelines tailored to our needs. And also because death and dying and suffering and pain might, for some people, be an issue. We were discussing, we had a side talk about if it is accepted by some people that we give relief from pain, or if it is not easily accepted by some people because of certain belief or moral or religious. So it should be clarified with the scholars like in Azhar and in the highest authority in Saudi Arabia, because I was surprised to hear from Dr. Azza and Dr. Sami that in spite of the fact that all religions do not accept that we suffer, Allah himself never likes that we suffer. He is very merciful. But they met some people who were saying, no painkillers. I do not want painkillers. It is against religion, my faith. So it was a surprise for me, but they illustrated it and made us aware about such an important issue that we will be working on it, or our group in the region, to make it clearer and clearer and clearer so that the doctor, the nurse, the psychologist can have, the tools and the help of the spiritual leaders in the region. I don't know if you can follow what I'm talking, or I was not understanding it. I thought, oh. Now, yes, the minimum service should be available, and quality service. Doctor said something very beautiful. I thought about the inventory we make. I make it in my hospital, and it's always, very sad to see that the family, of course, no one is happy to see his son dead or his daughter dead after a long suffering, even if he was having cancer. So he said, no, we don't make it at the end of the itinerary. We make it every time the patient or his family comes to consult the team, or every time the team, if it is the mobile team, goes to their home, they make them make like an inventory. It's in 1 or 2 seconds. How? They are having like the mobile phone. They ask them, now that you received the visit by the mobile palliative care team, or you went to the hospital. It's what?
Feedback, reflection.
Huh?
Reflection, feedback.
Feedback, yes. What do they think of what has been offered? Are they happy with what was offered? Or is there a defect that we can correct in our manner, in our way of doing things? I mean, we know the knowledge, we are the doctors, the nurses, the psychologists, but this is the patient. I mean, this is the family. We are together to work together. We see it from our perspective, but also they have to have their feedback. How did they receive this service? So that we improve our service. And the third, it's not because it's the last that it is the least important, but it is one of the most important, is to establish national and regional, locally, centers for training at the primary level, secondary, and third settings. I hope I could cover. I mean, if you have any question.
Yeah, so please start I may briefly. And also thinking about what could be done in 2 years. So that was a very nice summary. We heard one example from Saudi Arabia that there is centralized training for in palliative care for all levels of the healthcare system. So the idea that there could be an identification and a recommendation to establish a national training center to train staff who will do primary palliative care, mobile teams, who will work at district level or secondary level hospitals, particularly those two. And I think that that training could fit with what we heard from Dr. Nakhla about the intermediate level or the secondary level training, centralized training sites to assure the standards with all the efforts to make sure that whoever gets trained is doing it not just because their hospital boss sent them to get trained, and the quality measure is not just how many people were sitting in the training, but what they do with it. We also heard from Saudi Arabia, Dr. Al-Samari, that there are now about 30 new subspecialist palliative care trainees per year in Saudi Arabia. I know that in Lebanon and one other country there's specialist training, but I'm sure there's nowhere near as many. And it may be possible to admit 3 doctors per year from outside of Saudi Arabia to get specialist training. So a second proposal, and what might be able to be done in 2 years, is to identify and establish 1 or 2 regional palliative care specialist training programs to train specialists for the region. One, presumably in Saudi Arabia, because that already seems to be the possibility with some support from EMRO to convince the Ministry of Health to enable people from any country in the region to get specialist training there. But to begin to train, to begin a pipeline of training specialists for the region within 2 years. And then I think actually some of the easiest or easier to achieve objectives in 2 years that Dr. Reza mentioned. Using available existing clinical guidelines to develop a set of regional clinical guidelines for the EMRO region for both adults and children. And again, that's often an activity of a regional association. So that could be maybe something that could grow out of this group. And again, the wheel doesn't need to be reinvented because there are guidelines from many countries, from Saudi Arabia, from Vietnam, from developing countries. So that's a possibility. A set of minimum palliative care services that should be provided at each level. And again, we talked about mobile teams. Dr. Reza mentioned healthcare visitors. This is a term for also community health workers. So the model might vary, but it seems that in the region, mobile teams might be the predominant way to provide home care, as opposed to involving community health workers. But anyway, setting minimum standards for care at each level, which might include home care, whether it's provided by a mobile team or community health workers are involved. And finally, this idea of requesting from, maybe as a request from this group to the leading religious authorities for the predominant religion in the region, Islam. And these authorities, from what I hear, might be in Mecca and in Egypt, at Al-Azhar, to clarify or to comment on some of the key questions that are not, where there's not a lot of agreement in palliative care for Muslim patients, such as the issue of sedation and when can treatment of symptoms be used even at the risk of sedation near the end of life, and use of life-saving treatment. Those, I thought, seemed like tasks that could be completed in 2 years. Others?
I wanted to add that, unfortunately, in the pediatric palliative care, there are not clear, specific guidelines for pediatric palliative care. All is taken from the adult palliative care textbooks and guidelines published. So it's not only in our region, it's all over the world. So since you are doing something for our region, let us start it, and by this way also the other nations or other regions can have our model, or we can collaborate later on with them, so that we are having with time some guidelines really approved and effectively proven for the children.
Thank you. I'm really, really pleased to see that you were talking about quality standards, and whenever you look at any definitions, standard definitions of quality in healthcare, it's not just the structure, the process and the outputs. The final step should always be outcomes, so change in patient health status, physical, mental and social well-being. And we do have really simple, clinically relevant tools to do that. So simple patient-reported outcome measures. And when you're moving out as specialists into generalist services, they become even more important. And the evidence we have from Africa is clinicians say, thank you, a really simple assessment tool that is brief, make sure we ask the important questions every time we can track patients' well-being over time. In pediatrics, and we're now rolling this out in Turkey and Jordan, which again will be the first parts of the globe beyond Africa that have done this. So I think there are tools that we can use, and it ties into the indicators issues as well, which help us maintain quality, and also support clinicians to undertake that detailed person-centered care that we need. So I really, really urge us to think about patient-reported outcomes when we're talking about quality. It can be done, it's been done around the world, so it's not an unfeasible task.
A couple of issues from a WHO perspective. I don't know, I mean, excuse my ignorance, but when the minimum services by level, this is something that has been spelled out, I mean, beyond what we have as a guidance that you have now put together. But for me, I mean, as I mentioned, the Ministry of Health is one of the questions that will come up. What are the interventions you recommend? Care that the standard exists. If not, I mean, this is something that really, I mean, the
suggest you to highlight, and it can be, I mean, working on a publication or something, but tell you what are by level of care is internationally possible.
It's already published in the WHO in 2017.
Is that, well, disease control priorities is
Yes.
more detailed, but the guidance documents from WHO have
Yes.
addressed disease control priorities is more detailed.
But the Ministry of Health will never go to 3 guidance documents and look at it. What I'm saying is that you need to package it in a way that actually the elements are, we're discussing maybe it's related to our group points, is that how you package it in a way that there are clear elements that you say, these are the interventions, this is what can be done at the public level. By the way, I want to also tell you that we didn't touch upon humanitarian settings. This is something that might be, I mean, very difficult, but still, I think we need to think about what are the minimum elements that could be still, and we have been thinking of it even for more complex in diabetes management in situations like Syria, where you don't have access, is what are the minimum elements? It can be just a nurse in a point of care, just distributing some drug, having a kit or something, I don't know. But there are many issues about the model of care specifically for emergencies. But one of the starting points is that the core intervention, what are the core intervention by level of care that we can spell out. The second aspect is that to link guidelines so to essential medicine is that from a WHO perspective, you start on guidelines adaptation. It's not guidelines development at the regional level. Most of the time is whether adoption or adaptation. We rarely have full development of guidelines at the regional level. We basically expect it's you to do it. In the case of palliative care, we recently have the pain for adults that had been done, which was a formal process of guidelines through the guidelines review committee. And you know how tedious this can be, but I think sometimes we need it. I keep on saying to the colleague in HQ, when you don't have guidelines for the last 10 years, like on hypertension, and now we're asking ourselves whether we should consider it or not, it's okay, it takes 3 years to do it. But it stays at least 5, 10 years before the WHO come out with guidelines. So if there is a need to do it, maybe we need to push. Sometimes it's not easy to get, I mean, that clearance, and require a bit of resources. But my point is that if we are doing it at regional level, what I see, I'm receiving on a daily basis guidelines to review across a range of conditions for 22 countries. Most of the time, I don't see the process of guidelines, how the guidelines have been done. One of the unique countries that done it is Saudi Arabia, because you have actually a group that has been trained on how you adapt guidelines and describe the process, the committee, the systematic review, the PICOT question, the grading. I don't know if you want to enter that route for palliative care, but if they have to be endorsed by WHO, that process is at one point, even at the regional level, it would be difficult to get something. Otherwise, we can say, okay, this is a network activity, and it's useful for the countries, but it will never receive kind of guidelines with the stamp of WHO. It's a decision, but I'm just preempting this because this is something that I'm struggling with for all types of conditions, and the country want to have guidelines that are endorsed or supported or whatever by WHO. We have a very stringent process of doing it. We have not been able at the regional level still to come out with the procedures on how to adapt guidelines. We had a consultation 3 years ago, nothing really had come out as an approach. So as I mentioned, Saudi Arabia is a bit at the forefront because you have a committee, you have a process that is described. But sometimes it's not enough to have experts sitting around the table, coming up with adaptation, copying and paste, sometimes a group. It's okay, this is the guidelines, and we want them to endorse it. Doesn't work like that. It's something that we might think about. We want really to have documents, or sometimes, and more I see from HQ, we avoid the guidelines, so we keep it as a manual, operating manual, guidance, note, whatever type of formulation. Sometimes if the secretary look at it, they tend to react, but often it's not really a proper guidelines development. So this they need to mention, and I agree with what Professor Harding was mentioning about the quality assurance. Can we get something quite simple that would be rolled out in a couple of countries, link it to the pilot where you have the training? So you have a package that is really something that goes across them. You have a policy dialogue, you have a selected maybe sites, There might be some tools that you want to develop in terms of readiness of those sites before starting. We've done it in other conditions. That are we ready, and are there a certain number of element criteria for readiness to make sure that you have all the building blocks element in place before starting it. And then you have the aspect of monitoring and quality assurance that might be also in some sites where things are already ongoing, you can already use this what exists and develop it. In order, we need to have a consensus of what would be the element of progress and the quality indicators. We have an effort at the MRO on primary care. 3 years ago, we developed 34 indicators for primary care quality indicators, cut across a dimension of patient satisfaction. Some are related to specific conditions like hypertension control or whatever. It has not been piloted across the region. To be frank, and there are a couple of countries that already use it on a regular basis. So it has to be very simple, limited set, because you are just adding to what already exists. And in many countries, they have more than 50, 60 indicators at the primary care level. Specifically for that level, it has to be something really, really limited.
Okay, a lot of stuff. When you talked about the 3 levels and the essential services, you mentioned some things. Steve, you said we need to talk to them about what, we need to talk to governments about what you used really nice fancy terms. Do you remember what you said about those levels?
Yeah, I mean, just the range of intervention by level.
Okay. So the interventions expected at these levels.
The minimum service package.
In the levels of service. And before you said that, what I was thinking is I'm imagining I'm a government official and I'm getting these WHO recommendations and I look at, okay, these are the minimum standards of primary care, secondary care, tertiary care, implement, and I look at them and I go, I mean, really, we're starting from nothing. And if they get something that's so overwhelming, the chance that it's a non-starter is really high. And so I think as a group, if we come up and because we're coming from the WHO guidelines that say primary care, I think if we, and it could be something else, we could decide as a group it's something else, but coming to governments with, these are the minimum standards at all levels, etc. These are the recommendations, but if you're only going to do one thing, this is what we want to do, and these are the outcomes or indicators or whatever that we expect. Then it makes it much more feasible and accessible. I think it's just too overwhelming to, this is beautiful, but I don't think it's realistic. And so as a group, just coming up with one, this is the first step, and it becomes a bar that's they can see and make it something they can accomplish.
Just a quick comment on that. When we, a couple of years ago, produced what we call the package of essential intervention for non-communicable disease, some of the high-income countries came back to us saying this is a poor package for poor countries. And we say, no, these are core elements for all countries. But actually, the packaging was important. My point is that I agree, we need to start at the primary care level. But there are countries in our region that we say, I mean, clearly the GCC countries will not accept something that stays just at the low income. They are already thinking of improving, and we might have a question when we do some evaluation sometimes, despite the fact that it's already developed, we see there are gaps, there are things that we have to improve. My point is that as we are a very diverse country, region, we might think still of element that what do they need to take for? And I think that even though I have done an evaluation of primary care 3 years ago in Saudi Arabia, I still think that there was a lot of things that we could also improve, despite the fact that we have already a lot of services that are in places. It will depend on how also we want to engage with the policymakers, because my fear, specifically for the GCC country, even if they value the primary care approach, they see that things are already there, and they would like to have tertiary, and this was a bit also what came out of the group, that the tertiary aspect is there. So we don't have to bias and push towards what's already I think it's for me often the mistake that we invest all our resources in tertiary hospitals, super sophisticated, but actually primary care requires still a lot of fixing. But at the same time, giving them the ability to, these are policy options, the list of options that we could also for them choose from.
It can also be a tiered approach.
Yeah.
These are the first, as you say, the first steps, particularly for countries that have very little. But it should not just be that. It should also be, if that's already in place, then this, and then this. And it can be aspirational, because this needs to be thought of as not just something that's done in a year or two, but over many years.
As a region with so much diversity, I was thinking the same thing when you were talking about specialist training. I think there's so much diversity that on all of these working groups, we should maybe consider a tiered approach, or making recommendations, and governments can pick from one what's priority for them. Because also in training, I really honestly don't see somebody from Morocco or Tunisia getting training in Saudi Arabia, and probably not even from Jordan or Lebanon. I see maybe for training 3 discrete regions, the North Africa and the Fertile Crescent and the GCC, but then that leaves Pakistan, Afghanistan, etc. So thinking tiered in terms of region, because we are on some level culturally different and we have different needs, but also in terms of income setting, and then maybe having a special group of humanitarian crisis that we think for each set of recommendations that we make, and maybe we set them in level of priority and make it possible for governments to select what makes the most sense for them.
In 2012, we had a Rotary Committee paper that was grouping countries in the region. It has not super been accepted by countries, and now it's not. Basically, it was that attempt to say we have countries that are different level of income, health system development, performance of the health systems, and basically when you look at the ecological profile, it's pretty much matching in some of the countries. So we have a kind of group 1, group 2, group 3. Now with the crisis, with the conflict settings, this has been wiped out. I mean, like Syria was in group 2, so we have a middle-income countries that bring together, Iran, Morocco, Tunisia, Syria. It's no longer effective. But we use actually to have that approach. In some countries, it helps us because they are at the same level where you have nothing integrated, and you're starting almost from scratch. And it had given me an example of how we can do it and what are the priority action for those. I think a tiered approach would be important, plus something specific for humanitarian setting, without grouping the countries, because I think this is no longer something that we would recommend, but at least for element, and then we can say, as a starting point, we have a time frame of 2 years. Pragmatically, we would like to focus on this first. The rest might come later, and we don't need even to outline it at this stage. But I think there should be some consensus among the groups about priority settings in the coming 2 years. We have a big list of intervention and action that we would like to put together, but maybe for 1 year, this is what we would like to focus on, thinking that perhaps there are things that might come as we move on, as we build our capacity, as we work together. And I think this is something that it's up to you to decide.
So there are 2 things I want to comment on. In Uganda, the Great Palliative Care Unit, they have very nice guidelines. We have been adapting them in Sudan, and they were fitting us very well. Now they are developing pediatric palliative care guidelines. So I think it's important to share them on us, and then we can see which countries can choose that. And the other thing, I think, to raise the level of palliative care and diffuse it, it's very important to have people of different specialties. So when we are speaking about training programs, to include, for example, nephrologists, cardiologists. So if we have these people, and then these people go back and in their setting they have the palliative care services, that will be a very good impact. Thank you.
I just want to comment on at the beginning of the primary care, as we go to the level of primary care or mobile team services. I mean, here we need the policy group to help us, because we have different, as we mentioned in our training group, human resources, that there are different regulations even in the GCC countries. For instance, I don't know about Saudi Arabia, but it's in Kuwait that the legitimate use of the opioids outside hospital is not yet approved. So how can you send a team home if they cannot control the pain? Of course, they can do some psychosocial support, probably some physiotherapy, but the main issue is the pain and symptom management. And if you are not having this eligibility, then there is no point of making any home care team or mobile team or focus on this step. Plus, who is going to provide this? Again, we have to say the person who should be sent home, he should be qualified to provide, because he will take the responsibility alone. And if you don't have enough qualified personnel to provide the service, again, we are facing that this level of service is not, you can say, applicable at this time. So first we have to change some of the regulations, and then we make sure that we have enough people to cover the home care services. I don't know how they do it in Saudi Arabia, probably.
Since 1 year, we overcome these obstacles. In primary health care center, we move the pharmacy from primary health care center at all. There is no pharmacy. And any patient seen and completed by a physician, he will receive a SMS message that your medication available in the private pharmacy X or Y, the nearest one for
opioids.
So even so we can go there and take it. This is safe. So there is no medication in primary health care anymore. It is in the private sector.
What about injectable forms? Are you talking about the oral?
The oral medication.
No, I'm talking about when we want to provide home care service, especially at end of life, we need injectable forms sometimes. Because the oral one we can dispense to them in the outpatient clinic. About injectable forms, how did you manage to do it?
I think we still have the batteries and some liquid.
No, we are talking about different issues. We still have these, but I mean, sometimes you need.
The majority of patients, about 90%, treat with either oral or something
or
subcutaneous. But if there is any difficulty, the patient needs infusion, he can come back either to the hospice or the secondary hospital to take the treatment.
Oh, this is what I say. I mean, it's not a home care then service. Plus, subcutaneous means injectable forms. Anything which is injectable is not allowed to be used outside hospital.
It is allowed in Saudi.
Oh, this is what I mean. I'm trying to get from your experience how
it is just changing the policy.
This is why we need our policy group to suggest for us some kind of way to convince the governments to do the same.
Yes, but I mean, usually, if I'm not mistaken, patients who are dying or their families, they prefer that their member who is dying dies at home. So if we make him go back to the hospital to have IV fluids, this we are not working properly. We are spoiling the system. He will die in a hospital, yes, but like a homeless person. The best way of dying is to die in peace and in dignity. Of course, not suffering, but not also being abandoned and neglected. But I believe that the mobile team can go home during the last hours or last days and provide the best care there, better than at the hospital. And these are going to provide respite care, supportive social, and moral and spiritual care.
Oh, this is the point. The idea was not we are against the step. we want to implement this, that we want to get the others' experience, how they manage to convince governments, and that's all. The idea was what we can achieve within the current situation.
I think Asma has some.
In Morocco, we can use injectable morphine at home, and we train the caregivers to use it at home. So we have a little program, l'école de l'aide naturelle, school of caregiver. We train them to use subcutaneous morphine for his parents at home, because the team home care can't be there all the time, so it's not economic to train the caregivers to provide the palliative care to his parents.
That's interesting. Do you have a curriculum that you use, or what you train them in, or is it?
Yeah. To treat to use morphine subcutaneous, to treat
wounds, pressure ulcers.
Yeah. So the caregiver do a majorité this one.
So caregivers do the majority of care at home, and they have a caregiver training.
Because in the first consultation, we identify the caregiver, the principal caregiver, and we give him training.
Which means that the government approved using of
C'est une expérience individuelle.
This is why it's very, very individual from country to country.
But I think that that will be easy to convince governments because c'est moins coûteux.
C'est cheaper.
Yeah. La prise en charge est moins coûteuse, conséquence.
We have 45 minutes left for the last group. Just looking for this group, perhaps maybe you are clear, I'm not entirely clear of what would be the action point for this group in terms of deliverables. I heard a couple of elements around a training, and it relates somehow to the first group, and just discussing which level of training is something more specialized training, what I understood for, tertiary care level. There was the issue of adaptation of the guidelines. We raised whether we want to have kind of development identification of simple quality indicators, patient outcome measures that might be reported across a number of countries. Now also as part of the training, we've been extending to caregivers. Maybe we can refine it together, but I would like to see, like it was for the first group, something about what are the key actions. Just now for the service and the minimum service also level, what would be the description? We might think also about how the regulatory aspects of human resources and prescription rights exist across the region. Just mapping out what the nurses is able to do, not to do specifically when the use of controlled medicine is involved, or even caregivers if you want to expand. But I'm not sure that we are entirely there on that group in terms of all of us, in terms of the action and deliverables as it was for the first group. So maybe I don't know if you want to comment on that.
Yeah, so 2-year deliverables.
Huh?
2-year deliverables, yeah. So, you want me to take that thing? So, again, trying to coordinate with what's been said already and think about feasibility. There was the idea of I guess a lot of it is really recommendations of this group. So one would be just thinking about what this group could produce and what recommendations it could make for what other parties could do. So, this group could maybe produce some things, but other things would require the involvement of people in countries. And, we don't have control over that, but it could be an aspiration. So, for example, the recommendation could be to identify a site to provide basic and intermediate level training for the country, and to offer technical assistance to establish such a center and begin training.
Perhaps because this point is related to what the first group had mentioned, is that if you are coming out with a curriculum, then you have to put some criteria about the sites and where the sites of training might take place. So these two, I see them, linked.
Right.
Just the consensus is that, are we going to focus more on training for palliative care, mainly, or infantry at the second level, but still focusing on PHC, or are we concentrating more on programs that are specialized palliative care program at the tertiary level, or both, but knowing that we have a time frame that is short, that, as I mentioned, we need probably to have prioritization, that, okay, what are the steps? We start maybe like creating a curriculum, secondary level, targeting primary care providers, we identify the sites in different countries, might be different sites. If those sites become a centralized training center, I don't know at this stage. And do we need this now to identify this? I think that this cannot happen without a discussion with the national, with the ministries that know what they would like to put together.
Right.
So the selection of the site, and this is where I started even before coming here, when there was this idea of having hubs, original hubs for training. I think for me, it's premature to now select already one or two countries and say, okay, these are the hubs where we'll do the training. That we can share opportunities of training, even formally through the network, that, okay, we have ability in this country maybe to provide specialized training for X number of people that might be coming from other countries. This we can start even today. But as part of an organized plan of action for 2 years, I thought that agree on the curriculum, yes, but most probably there will be a national level discussion where the sites of training might happen. But I wouldn't select a kind of training center now. I don't know, this is something that the group might come.
Sorry. I'm not from the group, but I think the task of this group is service delivery. So I think they should be speaking about how to initiate services where, especially there are also services in palliative care, whether at primary level or at the tertiary level. So it can be like speaking to the Ministry of Health, speaking to hospitals to have palliative care units in different settings, especially when you already have the training. So if you already trained a couple of people from a certain hospital, now they are ready to provide the service. Then the next step, please, we want the service to start. You already have the people trained. So what are the referral pathways to be done in this hospital? How is morphine going to be available? The drugs, the supplies that are needed for this to start the service.
So I think I have so talking to ministries of health is not a really, it's necessary, but not a really clear outcome. So I'm maybe trying to think more precisely and specifically about 2-year outcomes for this group. So number one is that, as I think you mentioned, there are already multiple training curricula. The curriculum that's in the WHO guidance documents is just a summary of the basic course of palliative care that my group from Harvard has been teaching all over the world for about 15 years. So with the APCA curriculum, with the Harvard curriculum, with curriculum from Saudi Arabia and from other sites, perhaps there could be a production within 2 years, a review by our group, and a production of 2 kinds of curricula. And again, I would suggest this for both undergraduates and for postgraduates. One is a discrete course, a curriculum for a discrete course that would be adaptable, but a basic curriculum for a discrete course that could be taught in 1 week, whether for sixth year or final year medical students or for postgraduates. The second, and again, we're doing this in multiple sites, is a set of training materials that can be used for integration into undergraduate curricula longitudinally through the course of undergraduate medical training, if countries want to do that. That's one potential output achievable in 2 years. A second would be, again, based on existing criteria from APCA, from Saudi Arabia, from other countries, regional clinical guidelines. And I dare to use the word guideline because I think it should not be endorsed by WHO, because to get that would take probably until I've been dead for 20 years. So, or maybe only 10 years. So I think that unfortunately it cannot be, and for legitimate reasons, it cannot be endorsed by WHO, but maybe could be a production of this group without getting our dear colleagues who've made all this possible into any trouble. And finally, publishing a set of tiered recommendations for minimum palliative care services. And again, this would need to connect with the training that would be required for them, but to publish something like that, which would be constructed in such a way so that countries that have nothing would have a place to start, countries that are already very well developed can fill gaps in the system or progress beyond that. And then finally, plus minus some sort of recommendation for spiritual, for guidance from the Islamic scholars.
Few comments, I agree, but most of their activities, at least 3 of them, 2 of them initially falls, and we can then it's arbitrary distinction that we are making. It falls under the group number 2, the group on health workforce that include education, workforce training, and guidelines adaptation. But I was thinking more on the services, multidisciplinary. What does it mean? The role and function of each of those providers. In countries where you don't have community health workers or caregivers or whatever, the role of caregivers from the experience from the region, is it something that exists? And then link it to the minimum service package in terms of distribution of role and what are you doing in terms of element of assessment, pain management, whatever. And having something that is quite simple, that just detail, because this is a model of care. They are less relevant to the content, to guidelines, or training, but more about how we organize services for palliative care, starting with the primary care level. When you have a diversity of countries in terms of using nurses, maybe we can link it also to the question about regulation of the health workforce and the ability to prescribe, not prescribe. I think this is why I would see this usefulness. Okay, if we are doing pain management, but actually the nurse cannot do much than assessing pain, or they don't have the right to prescribe, then we will applaud. I'm not sure that we have even that. Do we have a regional view of what are the human resources and their role and the of regulation, the right they have?
I think we can pretty much say across the board that nurses cannot prescribe in the region, period.
Yeah.
And it will be a very, very far reach for nurses to prescribe.
Agreed.
But we do have experience. Usually, palliative care patients will go, will come from oncology side or from cardiology or whatever, or the internal medicine. Those patients with narcotics usually started by specialized palliative care, and we send only for home who's relatively stable and decide to end the life in the home. So the plan is already written, and the job of them is when they visit the patient in home, just to make sure that this type of medication is suitable, overdose, or under treatment. So she's the one capable to decide. I think this patient is suffering. She will give the recommendation for primary physician to increase the dose or decrease the dose, but she's definitely not the one who write the prescription. There is a primary family physician who will guide, who will obey her guidance and judgment from the nurse.
And it's only an end-of-life care.
Yes.
So, I mean, those are two limitations.
In that case, I mean, this group, what I would expect more is that maybe we can start with just case studies of model of care as they exist in the region, documenting them, because I don't know, I mean, we are all talking about mobile clinics. I mean, I went, I don't know in how many countries in rural areas. I don't see this happening even, I mean, for basic elemental. So are we serious about, does it exist? Do we have, I mean, documentation? Does it work? Is it just a pilot? Is it something that has been scaled up at the country level? I'm not sure that we are really there. So maybe this group could just start by saying, collecting what we mean by model of care for palliative care. What exists in the region? Can we document innovation? Some people have even, mobile health has been, this is something that we could envisage, and then start with this, because it will be a very nice, and it will link also to the policy level where we're discussing that. To make our case, we may maybe start to say, okay, because the ministry said, what is out there? They will ask us, what do you have experiences elsewhere in the region that we might learn from, in Saudi Arabia and others. I think it could be a starting point. And I would like still to mention the quality assurance thing. I would like to have something that maybe as an activity would start somewhere. So if we have tools that are simple to maybe adapt and select a certain number of countries, why not? Can we start to have, and linking it to the countries where we have some training and some pilot improvements that we would like to do. And so, okay, we pilot those quality, and at the same time, we can discuss in parallel a set of indicators that we agree upon to measure progress over time. But I think the focus of this group, for me, is really should be left to model of care. Of course, we can link it to the training, to all the aspects, but model of care of quality assurance would be an important element that so far I didn't see mentioned in the activity.
Just on this, listening to this conversation, I think what is important is sharing information, and at some point we try to have a platform at headquarters to do this. So to facilitate exchange, discussion of country cases, and also sharing documents, because for example, the guidelines, you have the guidelines for adults, I mentioned yesterday, the guidelines for pain control in children are being reviewed. And actually, Eric, I'm happy to tell you that our DG asked us to do this in 2 months. Which is not going to happen either.
Well, it's okay, because you'll pay us so much money.
But the commitment is to have these new guidelines for children pain treatment early next year. So I think it's important to share this document, maybe also national guidelines, and to share experience. Because the models of care, it cannot be a top-down exercise, but you can be inspired by other countries. So maybe a concrete commitment could be to have a web portal for the region. Now, this is a real commitment because you need someone to spend time on it, and to coordinate this, but I think it's extremely useful because it's a way to, it's in addition to the training, it has a different impact, but it's really a way to create a new knowledge. So this could be maybe something useful for the region if a couple of people here want to commit. As Slim was saying, there is an incentive to have a longer term commitment with this group. So maybe this can be an important tool in addition to what has to be done with the training.
So following what Salim asked for, again, trying to be as concrete as possible. Richard was being very modest, and he didn't say anything about the palliative outcome scale. So a very concrete and simple way to do something about quality assurance is the palliative outcome scale, which is very short, has been validated in Arabic, I'm told. Right, Dr. Himba? Yes. And what we have done and others have done in various sites is to integrate this very short assessment of physical, psychological, social, and spiritual suffering and caregiver suffering into standard paperwork, hospital histories when patients are first evaluated by palliative care teams. And a very simple and common technique is to do a baseline evaluation in some sites using the palliative outcome scale, an initial evaluation to find out, to assess all different types of suffering, and then a repeat evaluation after 3 days, 1 week, at the second home visit if it's not a patient in the hospital. And that's a very simple assessment of quality of palliative care services that's feasible with existing materials.
I think one of the good tools to do that, what we call, we adapt ESAS, Edmonton scale, or symptoms management. And we have quality assurance that any admission patient within 72 hours should have decreased at least 50% of the symptoms. And this is one of the tools. Other tools is any patient who are admitted inside the hospital or in the community should have a family meetings completed. So this is the percentage is more than 80%. Any patient should have a complete assessment from physical, spiritual, psychology, social, practitioner, etc. within 24 hours. And consultation should be seen within 24 hours. This is one of the tools, and etc. And the last one is patient satisfaction, patient experience. This is really a matter for our new doctors.
We've really advised this group to consider thinking of putting together some case studies, document that could be a tool for us to use for advocacy, to show what already things are going, and just talking about something abstract, but actually there are improvements that are being made in this field already in a couple of countries. And we can, look at them deeper into what aspect these case studies might cover. Some aspect would be on the quality, some aspect about the multidisciplinarity. But actually then we'll have a range of key messages about what palliative care is about. Actually, this will help us, and it's a good introduction for the next group feedback on policy, because we wanted also to raise a bit the profile and have the policy makers and maybe other stakeholders understanding what is it about and how we can scale up and improve palliative care. But I think having a kind of template that we can support you in reporting on case studies and saying what kind of format we can give it to it, whether it's a leaflet, a publication, it can be an article that just introduce some of the elements of palliative care as we see it, and then I can just summarize some short experiences so far in the region and making a set of recommendations at the end.
And lessons learned. Also,
it can be a very good article that can be published. Actually, this is how also the group somehow get also some incentive, is that you are commonly then involved as authors in a publication. It becomes, the name of the group, if you want even to crystallize it into an advocacy group, you have something that then you start publishing under the name, and this is multi-country type of approach. I think it will be very strong as a kind of advocacy tool, and to use this network as well without putting them specific research, but more documents that also important for policymakers to know. So it's yours. We will now address the policy, and we have We have heard a lot of older groups, so might cut across from what you have already heard.
Hi. So we still have part of the process, the policy. And first of all, we discussed the need to integrate with the other groups, the services and the human resource, to integrate with them in order to see the reflection of them on the policy, how you need to see, to read, okay? Oh, sorry. Thank you. And you need to hear from them about how more details, how we move from the details to the action, and see get benefit for and use their advisory point of view, and see how that view impact on the policy. And then we started with we should emphasizes, or should we understand the political issue in the region? We are in the region with diversity. We talk about the different level about healthcare, level of palliative care in the region, from the countries with no services, with no national program, with no subspecialty, to the region and countries with advanced care like Jordan and Saudi Arabia. And understanding the difference and diversity between these countries in the region, we should understand that and address the how they are different in policy about regulation of opioid, DNR, accessibility to the opioid, also the conception and about awareness of palliative care, about health care provider and the health system in these countries, how that's different. There is a misconception between the palliative care and terminal care. Terminal care in the area, some of countries or services, they reluctant because of they connect this care with terminal care, with the death. And so we talk about and offer to doing some movie or some short movie to address the need for palliative care and show evidence about how the palliative care improve the outcome, affect the cost, decrease hospitalization, and then we move from political issue to our priority and how the political issue affect the priority. We talk about policy brief. We should understand the situation in the region by ask about evidence. We need evidence, and give me from each countries. Give me your evidence, studies. What is the cost of terminal patient? How that affect the cost and prolonged hospitalization in your countries? How that affect the cost, and how in advanced countries we also ask about a study about the effect of home services and palliative care and the cost effective. And we also talk about Tissam with the I think Lancet region, and that say there is introducing palliative care may be related. There is something related to the suffering about serious illness and chronic illness reached to about 170%. And then Tissam, I think you talk about opioid price watch, and I want you to just explain them.
So just explain that statistically. I've just sent the paper around to you. So using the WHO mortality data 2016 to 2060 and applying the Lancet Commission method of death and serious health-related suffering. We just published a paper this year in Lancet Global Health, and I've just looked at it this morning, and this region is going to have the highest proportionate change in death and serious health-related suffering in the world. 170% increase by 2060, highest in the world by far. So that's quite an important thing in your policy group.
Yeah, the point with the policy brief, I mean, is how to put this on the agenda of policymakers to make sense that this is important, that it's not just begging and knocking at their door with no solution. I think I really got your point that we need to be an narrative of just saying, oh, we want a place, that we have a solution, we have things that we can demonstrate. We thought that a policy brief that bring together from situation analysis, the burden, the trends, the element of current capacity, whatever experiences, as we discussed earlier, of model of care. And then raise also the possible return of investment. If you're investing in the right direction, what would you get of it? And the last point is about opioid, maybe getting the survey, maybe you can go, because we have, I didn't even know that we have an opioid survey that is a methodology that we use, validated by WHO.
So an element of the policy is to increase accessibility and availability of opioids for pain medicines for palliative care patients. So at the International Institution for Hospice and Palliative Care, which we are in an official relationship with WHO, we conducted this survey where we looked at not only availability of opioids in patients, so we're more interested in what happens when patients leave the hospitals. So looking at community pharmacies and looking at the regions and rural areas and whatnot. And we basically surveyed the availability. So there are 5 essential opioids available: hydromorphone, methadone, oxycodone, morphine, and fentanyl. How much will it cost the patient, and compared it to how much a minimum wage of a patient makes in a month. And then also affordability and accessibility. How long does it take a patient to commute from by road to downtown or whatever? And we actually had 4 participants from the region. We had Lebanon, we had Egypt, and we had Iran and Saudi Arabia, actually. That's someone report back.
It was the same country that had been included in the Health Action National Survey on NCDC.
Okay, that's good. So we use this right now, we're trying to use this right now as a model, as a tool to basically change legislation in terms of restrictive policies that forbid accessibility and talking pricing also. Right now we're doing work in Kyrgyzstan where we're using this data to advocate for the restrictive legislative that exists in plan and how can we change it, how can we change national policy, and also we are using it to and also in Kyrgyzstan to create a national policy on pain management and go back to training. How do you train the trainer, to different disciplines and whatnot. So this is a valuable tool that we can totally use.
Thank you. Then we move to address the misconception about palliative care between the public community healthcare provider and the policymaker. And we emphasize and focus on finding someone who can reach the political or influence the political maker in the countries, and by get help of NGO, get some regional collaboration, and we should start from point. This is about the country with low level or no level. They should start from a point by finding someone or some group that committed with integrating and introducing palliative care, and then influence on policy maker in the countries. Then we move to how find some source of financial source, and that's maybe we can get help from social affairs services. We connect between the Ministry of Health and Ministry of Social Affairs. is that some connection is possible in some countries, not all of countries. And that can be by doing some meeting and show some example, some studies in the region, pilot study, and some educational lectures or educational meeting, and about standards of policy, and give example for success example from that country and that country. And then we address the financial barrier. It is a difficult situation how to address financial barrier, because it is different from one set to another set, but maybe we encourage the government to cover cover the palliative care under the national package, and some we maybe offer some to NGO or some regional or international collaboration to invest on palliative care. I think if you, Sim, can add something to the
Yeah, a couple of points. I mean, I would split it mainly in two aspects. One is to get the
yes, thank you, because I didn't see
relate to the policy dialogue that we are doing to make changes in the training. So I think that in order to go to the Ministry of Health and you have 5 minutes pitch to make, you need to get some work. So having some ammunition, I think so. All the discussion about the policy brief, what I see this group of activities, one to get as much as possible the there. Try to tailor it to the region if we have country where we have data. So estimates of palliative care needs, the trend, future trends, the current capacity, and case studies that we might have about what is happening. Maybe mapping out those stakeholders that were not here today, and civil society, NGOs that you know, that might be also voices that we might mobilize to make the case. Progressively, I've been getting this into a package or a certain number of products. It could be a policy brief. I was thinking that the issue of advocacy for the public and the policymakers might be linked around some PR communication points. So the film was an example, because I mean, you know, we can have using the regional committee as a platform for next year. If we are ready, we can say, okay, we have a pre-session on palliative care. Depending on the group willingness, it can be more or less formal. We can say we have an action plan. We have set up a committee last year. There was a meeting that took place. We come up with a roadmap or draft roadmap. We refine it into an action plan with activities across the 2 years, and this is what we are presenting to you. And in the introduction, you show a film. We have a certain number of publications ready in policy brief. You have a platform and you use it. My point is that it can be very concrete, and then we can decide where we can make our case, find opportunities across the region, whatever conferences, whatever. I mean, and we try to, but we need to get ready first in terms of what are the arguments. So argument about the burden, ecological trends, argument about the cost and the return of investment, argument about opioid policies and how restrictive they are, but beyond opioids is essential medicine for palliative care and how we can make our case. This can be sub-products that you decide to do. And as I mentioned, if we want to bring all this together, it can be formally through an action plan or the finalized roadmap, which we present maybe next year or the year after, if you want to have additional time, formally to our member state. But I think using those WHO platform when we have the ministerial attention, I think it's a good way to put it, but we need to get prepared. So basically, I see it very difficult somehow to get all this for the next RC, because basically the RC planning starts in February, and by March you have already the program done. So I don't see, I don't know if Danny with the group will be ready for that, but at least think about those platforms and getting your message out. The other aspect on the advocacy for the public, we discussed, death perception, palliative care perception in the communities, how we can use NGOs, civil society, patient representative, maybe to expand also this group. And here the communication might be, or the case studies might be something that we give a face also to the region. I would really value a field like similar to what we have done, that can maybe cover 3, 4, 5 countries and give a voice, give a face to the people suffering, but also to the caregivers and the people trying to do something about it. This would be very strong. If we can come up with something like this. It's less formal than just in the papers, but I think both activities might complement each other very well.
Okay. Just in terms of the film, I think if we do decide to use the media and make films, they really need to be good quality, because low quality works against you. Full disclosure, I have I get no financial benefit, but I do want to say, as you were talking, and I've mentioned this group to you before, the K2P group at the Faculty of Health Sciences here at AUB, K2P stands for Knowledge to Policy, headed by Fadia Jaddan. They do really, really excellent work. We use them to push integration of palliative care into health insurance here. And they put together research very well, put together an excellent policy brief that I'm happy to share with you, and then put together a stakeholder meeting and brought the key stakeholders around the table in July, and by March we had a ministerial decree putting coverage of palliative care as a priority and even putting numbers to that. So if we are thinking of a timeline of it's impossible for us to get something together by February, maybe if we have any resources at all, considering using that group to put together something for us, I think that might be a really good investment of resources. And by the way, Fadi is my best friend and third cousin.
Could I ask a question about that? This relates to several comments that were made about, what is the situation of, for example, home care and about the importance of gathering data. So as you presented, there's already the data collection from the non-communicable disease focal points in all the regions about palliative care is included in there's just questions on palliative care. So would it be useful to create another set of questions, not limited to NCDs, although a lot will be related to NCDs, but with more specific questions, for example, about what percentage, and maybe this would be for is there still a service delivery and safety focal point? Or now it's the IHS focal point? So integrated health services focal point, is home care, what percentage of people do greater than 50% of people in your country have access to palliative care by a nurse at home? Or
some of the questions already allude to that. They are not NCD, they are palliative care funding. Do you have it integrated in the strategy? Do you have home base? Is it at a primary care level? And opioid access. So basically, they are covering already some.
So if it's not needed, then it could save a lot of trouble. But I guess
it's not needed. The problem is that the answer you can get from different stakeholders that are more or less distant from the services that are actually provided. Someone sitting at the Ministry of Health might give you a view on policy strategies quite well, but on 50% availability of opioids at the primary care level, I doubt that answer will be a very precise one. But it's about, as I mentioned, the value of this questionnaire is that it's validated by government. It's a unique tool that we have that is something to say, this is a set of questions that you have validated.
And we are supposed even to document, if you are saying I have a strategy, they are supposed to upload. And when we have discrepancies, we tend to go back to them and say, okay, we are not aware of this, can you perhaps document it?
So the different set of questions, and again, it was a great privilege to participate in that project in 2017, but this could relate to the proposed minimum set of palliative care services, the tiered approach. And it could explore what exists now with keeping in mind what we think should exist or what this group would propose. And then that could be published to show what exists and what doesn't. And, there may be gaps in the countries that are at a high economic level, and there be, interesting availability in countries of low economic. So this would make policy and services and training fit together.
Certainly, we were expecting just the results are being analyzed. Just what we can do very simply as a starting point to compare 2015, 2017, where we are. And we have 22 countries and how they have answered to those. We can then, our validation we can do internally through the network, we know the real countries. So we might say, okay, do we make sense of this data and the results? Since 2015 up to now, we see changes that maybe have not been captured by this survey, and can you do something about it? I was thinking of doing it, just that the timeline is probably by the end of the year that we'll have the final result of the capacity survey.
I did talk to Dr. Cherry and the coordinators of NCD at headquarters when I first arrived at WHO and saw the survey. I had some suggestions, but he really thought it was very important to keep what they have, because then it can be used to measure change over time.
But that might be one outcome for us as a group, is to look at these when they come out at the end of the year and do a country check and validate those. Okay, with these, there's this interaction. There's so much. Time for a break? Yeah. Yes, actually, we're 5 minutes past. So lunch is from 1 to 2, and then we can regroup at 2.
Are we going to sit the same way? Should we, the chairs should be?
Do you want them to be in U again? Maybe we can ask them to put the tables in the U again.
Thank you for
Picture after lunch. Before you leave, I'm just going to ask Hassan to do a group picture after lunch. So maybe we regroup in 2. We'll do a group picture before we're too tired, because by 5 o'clock I don't think we'll look very good in group picture.
Yeah, we're just. Okay.